Okay, for some of you who don't know who I am, my name's Lawrence Carter. I'm a physician. I was past president at SMA. I'm from Hickory, North Carolina. Came down here and I look around, and after speaking with Dr. Zapetti, I was wondering, oh my gosh, look at all the familiar faces. So it's definitely good to see you all. Well, I'm going to be introducing our next speaker. Her name is Dr. Sonia Malhotra. And the neat thing about it is I just found out she was chief today. And again, she's the chief of palliative medicine and supportive care services at Tulane. So I think we all should give her a nice warm welcome to Dr. Malhotra. And she's going to present it. Yes. I actually saw her slide deck, so they're very colorful. I think you'll be very entertained. So the key thing is it's going to be talking about leading with compassion. Yes, compassion. You have to remember that. Evidence-based strategy for pain and palliative care. So,
right. Thank you so much. How's everyone doing today? It's cold in this room, which is good. It'll keep you all awake. If that doesn't keep you awake, my slide deck will, for sure, because it is quite colorful. So thank you so much for the introduction. My name is Sonia Malhotra. I practice palliative medicine. Now, how many of you walked in here thinking, oh my gosh, why is a palliative medicine doctor presenting pain? No? Okay, that's good. Did you all think I was the dying doctor? Because that is often a misconception. We'll talk a little bit about that. So I am an adult and pediatric palliative medicine physician. I did my training at Tulane in Med Peds, and then went to the University of Pittsburgh to do a dual fellowship in adult and pediatric palliative medicine. So a lot of what I'm going to talk about will overlap with what Dr. Prasad also spoke about, because palliative medicine doctors, we do similar things now to many other doctors, including addiction specialists. Our communities are growing, our patients are moving further upstream, and so we do have overlapping patient populations. And so I have no financial disclosures to give, unfortunately. I wish I did, but I don't. So today I'm going to do a few things. I'm going to discuss the use of opioids, including methadone, in cancer-related pain and other unique populations, focusing on sickle cell, because I know that Dr. Prasad alluded to that in her presentation. I'm going to speak a little bit more about that. And then I'm going to identify treatments and communication strategies used for chronic and multimodal pain management. How many of you manage pain, either on an outpatient or inpatient basis? Okay. Acute pain? Okay. Chronic pain? Teetering the line kind of pain, acute on chronic. Yeah. So I think most of us have those patient populations that are teetering, and certainly in palliative medicine, it's no different. So how many of you have worked with a palliative medicine team? Wonderful. Yay. How many of you have used opioids for your patients or prescribed them? Great. So some of this is going to be a review for you all. And yet my hope is, if you haven't received formalized education around equianalgesia, that I am able to provide that today. And then how many of you knew which opioid to choose and how much to dose it at when you first started prescribing opioids? Oh, I see a little, shaking of the hand. The interesting thing is, and I'm going to say y'all a lot because I'm from right down the road here in New Orleans. Many of us are given an institution, actually all of us, when we start training, are given an institutional DEA to prescribe opioids. Our residents, interns, fellows often do not know how to prescribe it. So part of my education today is giving you practical strategies, a practical framework that you can also guide your trainees on how to prescribe opioids when they are first starting out. So I'm going to put this cartoon up there. This is one of my first slides. And I love to put this slide up there because this is how I felt 10 years ago when I came back to New Orleans. And you can only imagine, I'm an adult and pediatric palliative medicine clinician. I walked up onto the pediatric floors and the nurses got very, very scared and wondered which child was dying. And through 10 years of education in this area and building of palliative medicine programs, I'm on my 4th hospital-based palliative medicine program currently. I've really flipped the switch where I'm not the Grim Reaper coming for every dying patient on the floor. In fact, I just rounded prior to coming here and saw so many patients that are upstream palliative care. They're sick. They're very, very sick, seriously ill, and yet they're not dying right away. And so that's why I'm here to talk about pain management, because I do a lot of that in my practice. And so I always like to start any presentation that I give talking about what is palliative medicine. And so I subscribe to what is called the Center to Advance Palliative Care, which defines palliative medicine as the care of anyone living, and notice I said living, not dying, from a serious illness. So we are truly the care of people living with serious illness. And so you may wonder, well, what do I do? Because I'm not an oncologist, I'm not a rheumatologist, I'm not a pulmonologist, I am an internist, a pediatrician, and I do palliative medicine for adults and kids. The three major tenets for seriously ill patients that we take care of is number one, pain and symptom management. And imagine any symptoms that affect the quality of life, those are patients' symptoms that we are caring for. So things like constipation, nausea, anxiety and depression. I'm not a psychiatrist. I happen to be married to a psychiatrist, so I always have a curbside consult. And yet I help to manage symptoms that affect the quality of life for seriously ill patients. The second part of what I do is communication around serious illness, talking to people about their goals of care, talking to them about their advanced care planning. The third piece of this is supporting patients and families through really tough times. I just saw in the ICU a 40-year-old man who's dying from his diffuse B-cell lymphoma. And so I was there supporting his 38-year-old wife as she's going through her 40-year-old husband dying. And then the last part of what I do is what is called hospice care, comfort care, end-of-life care. And so I want you all to think of this as palliative medicine is the care of anyone living with a serious illness. And this is what we do. We focus on the burden of illness, the burden of the symptoms that affect the quality of life. Patient and family centered. I often have to call families. I have a goals of care meeting that my resident just scheduled and texted me about tomorrow at 11 a.m. With the family that's driving over from Mississippi. And we can address issues of life completion and closure when people are ready. Now, news alert, and I hope I'm not breaking or bursting anyone's bubble in this room, but as good as we are, each and every one of us is going to die at some point. I hope I didn't ruin anyone's day. In fact, I hope I give you some hope that if we normalize death and dying for ourselves, we're in a better position to normalize it for our patients and their families. And then we're a continuum of care offered with curative and life-prolonging treatments. I actually have several patients that I graduate from palliative medicine clinic. I was in clinic on Tuesday. I actually graduated 2 patients from my clinic. They will go back to their primary care doctors and be taken care of. They're in cancer remission status. So the big point of saying all of this is palliative medicine is not just death and dying. We're not the Grim Reapers of medicine. We actually are a very hopeful service that can help further upstream in the care of serious illness. And this is a graphic for those who are more graphically inclined, like myself. Generally, palliative medicine doctors like to be involved when people become symptomatic from their serious illness, from their cancer, from their chronic lung disease, liver disease, heart disease. Generally, when we get to the Medicare hospice benefit or end of life, sure, we can take care of patients at that time, and yet we like to build those relationships much further upstream. Here are some of the challenges that palliative medicine doctors can deal with. Now, I have a master's in medical education, and the first thing they teach you in medical education is don't put up a busy slide. And I'm sorry I'm violating the rules of medical education, and yet I want you to get a sense of the breadth of challenges we can take care of. I'm going to focus on the first symptom of pain today. Just keep in mind that many palliative care doctors and much of our field is about managing these top 3 symptoms: pain, nausea and vomiting, and anxiety and depression. There's a whole slew of other things we can do, including end-of-life ethics, emotional support, and coordination of care. Where does a patient go after? I was involved in a patient's story last week. First time seeing him, one of my nurse practitioners had seen him long ago alongside one of my physicians. And he has a heart transplant and was about to punch his sister, who is his caregiver, because they got into a fight. And so part of my job last week in his room was coordinating his care, making sure that he has a safe place to go to after his heart transplant. And he's about 68 years old with a brand new heart. So making sure he's taken care of and has a safe discharge plan is an important part of what we do. And then you can see all the symptoms that we help to manage. So moving on, which patients benefit from palliative medicine? So when you all go back to your home institutions, thinking through which patients would a palliative medicine team help with? So any patient living, notice I said living, not dying, with an advanced and/or serious illness that has symptoms and/or communication challenges. Now, there are some tools for prognosis that we can all use in our practice because prognostication is very, very critically important. UCSF, the University of California, San Francisco, has this tool called eprognosis.com. How many of you work on an inpatient setting? Anyone? One or two? eprognosis.com is tailored for more of the inpatient clinician. There are certain variables that can be put in, and a mortality index is pumped out of that. So I have my residents and fellows use this quite often. For patients living with congestive heart failure or COPD, we generally want to see these patients when they are symptomatic from their COPD or CHF. And so we're looking at New York Heart Association classification 3 or 4 for CHF and/or gold staging 3 or 4 for COPD. Now, the American Society for Clinical Oncology is the one society that has committed to saying every patient with metastatic cancer should be seen by palliative medicine within 8 weeks of diagnosis. So if you are caring for metastatic cancer patients, those are very appropriate to get in with a palliative care clinician for symptom management, communication, and support. Anybody heard of the surprise question? The surprise question is a validated tool in various studies. Would you be surprised if your patient died within a year? If your answer is no, I would not be surprised if my patient died within a year. That is a patient that should be seen by palliative medicine. And then if your patients who are living with chronic illnesses have complications from their serious illness, so patients with sickle cell who have avascular necrosis, acute chest episodes, that have priapism recurrent or are on exchange transfusions, those are appropriate patients for most palliative care clinics. Moving right along, I'm going to move into my objective 1 because I always like to describe palliative medicine and then talking about what we do best, which is pain management. And so my first objective is to speak about the use of opioids in cancer-related pain. Now, I like to break pain down into 4 major categories. The first being nociceptive, and nociceptive pain can be of the somatic and/or visceral type. If you think about it, our whole body has nociceptors all over it, all over our peripheral somatic areas, and then also in our visceral hollow body organs. The second type of pain is neuropathic pain. Nerves can get irritated either from cancer, the inflammation from cancer, or just from other acute stressors. Bony musculoskeletal pain, I'm sure all of us have experienced. If anyone's ran a marathon, they've had musculoskeletal and bony pain. And then I like to define my 4th category as other, chronic and/or psychosomatic pain. And today what I'm going to do is go through these modalities, these different types of pain, and speak to some of the ways that we can use medications to help us and complementary techniques to help us in managing pain. So why does cancer cause pain? If we think about the pathophysiology of cancer, and I'm going to take you back to the old school because I'm getting older myself. I know it may not look like it. Hair dye is a beautiful thing. And yet, when I was training, we were taught immunology. All of your basic sciences are really critical, right? And so I'm going to take you back to the old school, to your basic sciences, right? And for many of you, you're like, oh God, I did not sign up to do that today. And yet when we think about cancer cells, let's think back to immunology. Cancer, as it is reproducing in the body and it is dying out from treatments, including chemotherapy and radiation therapy, can often release nociceptive noxious factors like interleukins. And if you remember the start of the cascade, IL-1, IL-6, cancer cells also can release tumor necrosis factor alpha, prostaglandins, cytokines. My favorite, substance P, or substance pain in the butt, because that is our delayed mediator of inflammation and causes delayed effects. Cancer cells are producing these inflammatory mediators. And what happens is, if you look at this graph, these inflammatory mediators can irritate nociceptors in the body, which then create that ascending pathway of pain. What happens also is that these inflammatory mediators can also stimulate mu receptors in the brain to create the descending pathways of pain. And so it's a vicious cycle for patients with cancer. As they release inflammation in the body, which happens through treatment and or through the cancer getting worse, these inflammatory mediators are circulating in the body. Okay? When we think about that, and these are the main culprits, and substance P, I'm not talking about nausea today, but substance P is very important for oncologists to manage, in the treatment of nausea. It's not just semantics. You're never going to hear me say narcotics. Why would you think I wouldn't say narcotics? Why am I saying opioids? What's that?
Other medicines can make people sleep. There are other things to be considered narcotic.
Sure. Other medicines can make people sleep. Anybody watch Law and Order SVU or any Law and Order? Right? All those cop shows always give such a negative connotation to narcs, right? The person got arrested for their narcs, right? So opioids is the correct medical term for these controlled pain substances. In fact, narcotics carry a legal and negative implication. These two studies out of my alma mater, University of Pittsburgh, and the VA in Pittsburgh, actually found that when clinicians use narcotics, their patients who actually needed opioids were unwilling to take them. And so we have to use destigmatizing language, especially for patients who need these medications to be better, okay? And so it's just semantics. I'm gonna get on my high horse just a little bit, if it's okay. Please, as a palliative care doctor, don't use the words withdrawal of care. Withdrawal of care, do we ever stop caring for our patients even when they're dying? Absolutely not. In fact, I would say that caring for dying people probably takes more care than your 15-minute clinic visit, right? Want is a very powerful word. I want to win the Mega Millions. I think it's at 880 million right now. I want to win that. And yet the reality is I probably won't. So instead of saying want, giving your medical recommendations is really important. DNR is simply if the heart stops, if the lungs stop, we will keep a person comfortable rather than thumping on their chest, shocking them, putting breathing tubes in. It doesn't mean that that dictates all of their care. So you still continue antibiotics or nutrition unless you've had conversations around that. I already talked about narcotics. We should call them pain medicines or opioids. And then do I have any med psych people in the room? Internal medicine, psychiatry? My psychiatrist husband loves when I say this. Competency is a legal term. Capacity is a medical term. And all of us as doctors in this room can determine patients' capacity. Don't give that to your psychiatrist. They'll hate you because they have enough to do, right? And I think Dr. Prasad, if she were here, she would agree with me on that. So let's go to the next slide. So why do opioids help cancer-related pain? If we think about the pathophysiology of inflammation, inflammatory mediators are sitting on nociceptors to transmit the ascending pathways of pain, and inflammatory mediators are sitting on the mu receptors in the brain to help in stimulating those descending pathways of pain. Opioids are first line in cancer-associated pain because opioids competitively bind mu receptors and help to stop that descending pathway of pain. And this is important to know because we need to normalize use of opioids when patients have active cancer. So for surgeons often will use opioids in post-operative pain, and the pathophysiology is very similar. You have inflammatory mediators from cutting tissue. The difference is that for surgeons, we anticipate that post-operative pain will improve somewhere between the 48 to 72-hour range. And so opioids should be used for a very time-limited period. For OB-GYNs, we ask them not to prescribe more than 7 days of opioids after a woman has a C-section, because by that time, post-operative acute pain should be better. And we expect that inflammation to improve. However, in cancer, it doesn't. So opioids are not equianalgesic. How many of you have seen an equianalgesic table? How many of you use equianalgesia calculators? Online calculators. Okay, one person. So we're going to go through this today. So this is what is called an equianalgesia table. Opioids are not created equal. However, we can make them equal if we do certain conversions. And I promise this is confusing for me. I'm not a very good math person. I am certainly not the tutor for my kids in math because I suck at it, frankly. And yet we're going to break this down into a much more simpler version. I will say one thing. There are many equianalgesic tables out there. The one that I use is based on a majority of pharmacology textbooks that I have explored. So what this equianalgesia table shows us is that 1 milligram of IV Dilaudid does not equal 1 milligram of IV morphine. I'm going to try to use this pointer up here if it's working. Every opioid can be related to oral morphine. Okay. When we look at equianalgesic opioids to morphine, there's none, right? Oral morphine is the gold standard. Every other opioid is more potent than oral morphine. Now, how many of y'all come from institutions or cities or locations where morphine is feared? I think in New Orleans, communities fear morphine, and yet it's probably the least potent. In fact, when we look at this, 1 milligram of IV Dilaudid, if we compare it to 1 milligram of IV morphine, it's not the same. If we take 10 divided by 1.5, that actually equals 6.67 milligrams. So 1 milligram of IV Dilaudid equals 6.67 milligrams of IV morphine. Okay, and this is something really challenging to explain to my residents and my fellows, that when you use IV opioids, you have to make them equianalgesic. I'm going to break this down even simpler. I have another chart, so let's go through that. Generally, I have sheets. I wasn't allowed to bring sheets here for you all to fill out, and yet I'm going to show you this chart. Now let's go through this. These are the different types of opioids that are important to know. Morphine, obviously, oxycodone, hydrocodone, hydromorphone, fentanyl, and methadone. And then there are other opioids like buprenorphine, which Dr. Prasad went through quite significantly. There's also oxymorphone or Opana that's used in some institutions. When we talk about PO short-acting opioids, morphine comes in a PO short-acting. It's known as MSIR, or morphine immediate release, or tincture of opium. Oxycodone also comes in a PO short-acting version called oxycodone or Percocet. Hydrocodone comes in a PO short-acting version called Vicodin, Lortab, or Norco. Hydromorphone also comes in a PO short-acting known as Dilaudid. When we think about these, and oxymorphone does as well, I'm sorry, which is called Opana IR. All short-acting PO opioids have an onset of 30 to 45 minutes, and they last in the system for 3 to 4 hours. okay? So when your patient's hurting, you have to tell them to take a dose of their short-acting opioid because it'll take about 30 to 45 minutes to kick in. Now let's look at IV opioids, right? So many of these come in IV format. The onset for IV opioids, and I know that we have a CRNA in this room, the onset is generally 5 to 20 minutes. IV opioids work much quicker than PO short-acting. They last in the system for about 1 to 2 hours. When we look at PO long-acting opioids, there's a few formulations of this. In the morphine category, there is MS-Contin. Then we have OxyContin. We actually have a long-acting dilaudid nowadays called Exaljo. And then we have a long-acting fentanyl called the Actique or the Lollipop. These have an onset of 2 to 3 hours, and they last in the system for about 8 to 12 hours, except for the fentanyl patch, which I will talk about. The fentanyl patch is the only patch outside of the buprenorphine patch. It kicks in within 6 to 8 hours, and it lasts in the system for 48 to 72 hours. Okay. Oftentimes, my trainees are like, well, doesn't that PO Percocet work quicker than PO morphine? No, they all have the same onset and duration. Okay. When we compare opioids to one another, the gold standard that we are comparing every opioid to is oral morphine. And so we have to think about this. Is this more potent or the same potency as oral morphine? And looking at this chart, you can see that all of the opioids up here are more potent than oral morphine. In fact, when we look at IV morphine, it is 3 times more potent. What that means is 1 milligram of IV morphine is equal to 3 oral morphine equivalents per dose. Okay. And when we calculate an oral morphine equivalent, it's a 24-hour calculation of all the opioids a patient has gotten. When we look at oxycodone or hydrocodone, those are 1.5 times more potent than oral morphine. Dilaudid is where we start to see the big differences. Okay. So oral dilaudid is 4 times more potent than oral morphine. So 1 milligram of oral dilaudid is equal to 4 milligrams of oral morphine. IV is really where the difference kicks in. 1 milligram of IV dilaudid is equal to 20 milligrams of oral morphine. Okay, quite a difference, right? And then fentanyl, the fentanyl patch is what most of us use. It has a 2 times potency. Fentanyl patches come in micrograms rather than milligrams, but it is 2 times, meaning 2 times as potent. So a 50 microgram fentanyl patch is the equivalent of 100 oral morphine equivalents per day. Okay, or 100 milligrams of oral morphine. Methadone, for the purposes of this lecture, I don't teach. We actually have a calculation that we can do to configure methadone, and the same thing with buprenorphine. Questions, comments, or concerns about the equianalgesia table before I move forward? So please, please don't think of Dilaudid as the same as morphine. They are not the same. You can make them the same. You just have to do the math to make them the same. Okay. And there are plenty of opioid calculators to make this the same. Any questions? Okay. So opioids have side effects. There are mu receptors in our brain. There are mu receptors in our terminal bronchioles. And there are mu receptors in our gut. Has anyone ever used opioids for breathlessness, for dyspnea? Yeah, there's a role because we have mu receptors in the terminal bronchioles. So for patients with advanced CHF or COPD that have breathlessness, often we will trial opioids to see if that helps with some of their breathing. Not only does it have a central effect, it also has that terminal bronchial effect. So mu receptors, because of their location, the #1 side effect for opioids is constipation. So any and all of your patients who are on opioids need to be on a bowel regimen. It can be whatever. It can be Senecot, it can be Miralax, it can be lactulose. Please don't use Colace. Why would I say not to use Colace? Does anybody use Colace as a bowel regimen? Yes, I know some of you all are laughing. So did anybody remember from the 1980s, and you know, that's my decade, best music ever, Salt and Pepper? Anybody listen to Salt and Pepper? Remember their big song, You Gotta push it real good, right? Colace mushes it, it doesn't push it, right? And so when you're on opioids, you don't need just to mush the poop, you got to actually push it. So that's why we advise against using Colace, using a laxative that actually pushes it, like Senokot, like Miralax, like lactulose. Constipation is the number one side effect of opioids. Pruritus, urticaria can also develop, nausea and vomiting, sedation, and meiosis. Now, the two side effects that are not dose dependent are constipation and meiosis. If it's going to happen, it's going to happen, right? It's not based on the dose. However, the others are. When people get used to their opioids, generally the itching, the nausea and vomiting, and the sedation will get better. Now, how many of you were thinking respiratory depression is a side effect of opioids? It's okay, be honest. Nobody's looking. Nobody's going to even remember at the end of this lecture if you said yes. So all patients need a bowel regimen. Respiratory depression, however, is not a side effect of opioids. Respiratory depression is a side effect of all of us not knowing how to dose opioids properly. If I go back to this chart, right, I cannot tell you how many clinicians I've worked with who have given opioid naive patients in the hospital 1 milligram of IV Dilaudid, thinking it is the same as 1 milligram of IV morphine. And now you all know it's not, right? In fact, 1 milligram of IV Dilaudid is 6.67 milligrams of IV morphine. So when we think about side effects, respiratory depression is a side effect of us not knowing how to use the equianalgesia table, not of the opioids themselves, okay? So here are some of the opioids and their excretion patterns. Morphine is not safe in renal failure. And for those who are doing MOC questions, like I have to do for internal medicine, this question sometimes pops up of, you know, byproducts of morphine. This M3G is highly renally excreted. If your kidneys are not working, it stacks up in the system and causes sedation and potentially respiratory depression. So morphine is not safe in renal failure. Oxycodone is okay, but not preferred, especially when creatinine clearance is less than 20. Fentanyl is not safe and it is contraindicated in liver failure. Methadone is okay in liver failure. Methadone is primarily excreted through the gut. So for your patients who are on methadone, it is really important to ask them about their bowel habits because it's not a matter of if they will get constipated, it's a matter of when. And then you got to get them pooping so that they can excrete their methadone and not get toxic off the levels. So this is my trash box of opioids, and it was very refreshing to hear Dr. Prasad when she was speaking. So I have Demerol, I have Cariprisidol or Soma, and Demerol being meperidine. I like to call this Tramadont rather than Tramadol because Tramadont goes into my trash box as well as codeine and heroin, and I'll tell you why. Meperidine or Demerol and Soma or Cariprisidol, they have mu activity. However, they also break down into barbiturates. And so they end up being more sedative in nature rather than analgesic. Tramadont is a partial mu agonist, which means it's a partial something else agonist. And tramadol works on norepinephrine and serotonin receptors. It can lower the seizure threshold. It can cause serotonin syndrome. And often tramadol in cancer patient populations interacts with every chemotherapeutic under the sun. So we don't use it. Now, codeine, in pediatrics, we hate codeine because codeine metabolizes straight into morphine. And so kids, especially that have very good liver and kidneys, can become very toxic off of codeine. And then one of my smart aleck medical students was like, well, Dr. Malhotra, doesn't heroin go into your trash box? Yes, heroin goes into the trash box of opioids. It is not a very stable compound. It has to be injected. And even when injected, it's not a very stable analgesic friendly compound. The ceiling effect. So some opioids have a ceiling, and after that ceiling, they don't provide any better analgesia, even if you dose them more frequently. Tramadol or Tramadont is one of those. If you dose it any more frequently than every 6 hours, you get no better analgesic effect. This is the same thing with acetaminophen or Tylenol. You may get an antipyretic effect. You will not get, an effect for pain. So cross tolerance. Has anyone heard of this concept of cross tolerance? Has anyone rotated opioids in their practice on patients? Went from one opioid to another? Yeah, so this concept of cross tolerance is when you are switching a patient's opioids, you should decrease the dose of the new opioid by 33 to 50% because your mu receptors are already saturated. And so you don't want to overdo it. You want to cut the new opioid dose down, keeping in mind that the mu receptors are already saturated with the old opioid. So methadone. I wanted to give methadone its due credit. And I know Dr. Prasad also mentioned some things about methadone. So methadone is a pure mu agonist, but it also has NMDA activity. NMDA in the brain is the receptor that produces glutamate. Glutamate is a neuroexcitatory transmitter. And so it is very notorious for causing and amplifying neuropathic pain. Methadone, the nice thing is it is zero order kinetics. If you remember that from pharmacology, it just keeps excreting in a linear pattern until it's out of the system. Now, the problem with methadone is everybody's guts work a little different, right? You ever have those clinicians whose like guts are like actively gurgling after they eat and some that it's not actively gurgling, right? I mean, everyone's gut works a little bit different. And so methadone really does depend on the gut. So some people excrete it faster than others. It is mostly hepatic breakdown with fecal excretion. The liver metabolites are inactive and it is a lipophilic substance. Its half-life is really long, anywhere from 2 to 60 hours, and it can extend up to 190 hours. So when we are dosing methadone, when we use it for pain management, and in fact, I have a patient right now at the hospital on methadone. He's got a history of metastatic prostate cancer, and he now has a new mass right behind his esophagus. So he's got 2 types of cancer now. He is on methadone. And so I just increased his dose on Monday, and I went in today and increased his dose again. So don't change the dose more frequently due to this long half-life, and certainly not any greater than every 3 days. The side effects of methadone generally are QTC prolongation. It is not a matter of if the QTC will prolong with methadone, it's when. So you do have to monitor EKGs when prescribing methadone for pain management. When we prescribe methadone for pain management, it's not that single dose that Dr. Prasad talked about. It's not the addiction dose of once a day, a big heavy dose. It's actually a dose broken down into twice a day or 3 times a day. It also has significant drug-drug interactions. So if your patients are on antibiotics like meropenem, probably not good to use methadone. And when we do use it for pain, it is BID or TID dosing. Yes?
So obviously we're talking about cancer, a lot.
Yeah.
Thank you. So when we're talking about treating cancer pain, we often end up with things like SSRIs and things like nausea medications. When I see QTC prolongations, citalopram and Zofran come up in my brain.
Absolutely.
Are these things we should be shying away from with methadone, or adjusting dose on with methadone, or tracking QTC?
That is a great question. My answer to the question of when you are using other QTC prolonging agents with methadone, it is vitally important to monitor EKGs, to see how much the QTC is being prolonged, and then as it prolongs, to back off of some of it. I have a 58-year-old patient with end-stage renal disease and calciphylaxis, gets nauseous after dialysis sessions. QTC lingers in the 500 range. I have not found any other medicine outside of methadone 2.5 BID to treat his pain related to his calciphylaxis. And he also had an amputation because his calciphylaxis, his wounds got infected. And so I've had to back off of his Zofran, his Phenergan, all of those antiemetics so that I can use the methadone because his QTC started prolonging greater than 500. He still teeters at the 500. And I watch it carefully, and as long as it doesn't go up dramatically, I keep him on the methadone.
How often do you watch it?
That's a great question. So how often do you monitor QTCs in a patient on methadone? You want to monitor them initially every 3 months until they're stable, and then you can move them to every 6 months and then every year if they're on a stable dose. Yep. And I always get a baseline EKG before I start the methadone so I know what I'm working with and how much the rate of change is. So methadone dosing, if you don't use my equation, which I'm going to tell you in the next slide, you could use this graph. I'm not smart enough to remember this. I have way too much going on in my life to remember this. I have 3 children. Heck, I can't remember what their math stuff is, right? And what their schedules look like. There is, though, this equation or this chart that you can use. And basically what this means is if a patient's using less than 100 milligrams of oral morphine or less than 100 oral morphine equivalents, you can use a 3-to-1 conversion of methadone. Okay, so if they're using 100 milligrams of oral morphine, then you would use sort of 10-to-1 or 3-to-1, 3 milligrams, I'm sorry, of methadone. Okay, methadone doesn't come in 3 milligram tablets, it comes in a 5 or a 10. Generally, we are thinking about methadone when people hit 300 oral morphine equivalents. That's really the best time to start considering it because then we don't have any other long actings that really work for a patient. This is my way of dosing methadone. It's this equation. And this is sort of the University of Pittsburgh, Mount Sinai way. This is what they teach all of their palliative care fellows. Oral morphine equivalent divided by 15 plus 15, dose reduced by 50%. Because of methadone's half-life being so long, it is really important to dose reduce it by 50%, okay? Because you don't want to make someone toxic for too quickly. If you use this equation, it's a little bit more aggressive than the chart that I put up here, just a little bit, but it does work out and I can do methadone conversions very quick. Remember, once you come up with this number, you're gonna divide that dose by twice a day or 3 times a day dosing. Questions about this? Comments, concerns? When I have patients who have opioid use disorder, like some of Dr. Prasad's patients that end up developing cancer, what I do is I take their once a day full dosing and I divide it into 2. So if they're on 120 milligrams of methadone, I basically will start them, I'll dose reduce them to about 40 twice a day, if that makes sense. So when to consider methadone? When you have max doses of your long-acting agents. When your patients are maxed out on their long-actings, their MS-Contin, their OxyContin, or their fentanyl patches. Generally, when you get to MS-Contin 100 3 times a day or a fentanyl patch of 150 micrograms, you want to then consider methadone. If they have a history of opioid use disorder or substance use disorder, those are important patients to consider methadone in. And then keep in mind, you got to check that QTC. Methadone, generally, we like to keep people on methadone who have a QTC less than 500. If they're teetering in the 510 range, I'll keep it on and just monitor it closely. And you want to eliminate all other QTC prolonging agents like Zofran, like your other linezolid or other things like that. Buprenorphine, I know Dr. Prasad went through this. She is the expert at this. I am not an addiction specialist, and yet I will tell you I use Bup for a lot of my patients with cancer who have a history of opioid use disorder. It can be effective for cancer-associated pain. The challenge becomes is when you're using pure mu agonists like oxycodone or oral dilaudid, you really shouldn't use more than 50 oral morphine equivalents of the pure mu agonists because buprenorphine, especially if you're using Suboxone, comes with naloxone. And so you can precipitate withdrawals in the patient and they don't like it. They don't feel good when they're using Suboxone plus a mu agonist. And Dr. Prasad spoke about these microdosing and macrodosing strategies. I have a very simple microdosing strategy if anyone's ever interested. It's basically putting on a Butrans patch and then starting at 2 milligrams of buprenorphine 3 times a day and moving that upwards every other day. So very, very easy dosing strategies to use Bup. Very safe medication. Also have to monitor QTC when it comes to buprenorphine. So let's go through a case. Miss B is a 45-year-old woman with newly diagnosed breast cancer. She has pain in her chest that radiates to the back, 10 out of 10. Imaging shows breast cancer, no compression signs, no bony mets. Her labs are normal. She has no kidney abnormalities. You want to put her on an opioid for her pain. Which opioid do you choose?
Inpatient or outpatient?
Let's say you're outpatient, because a majority of you are outpatient. What would you do with her? Outpatient. Where would you start her at? And she's opioid naive. Yes.
I have a basic question.
Sure.
In the beginning. Here's a 45-year-old lady. You don't have an obvious reason of why she has the cancer as far as a lesion is concerned. Now, here's the important thing. I'm a surgeon.
Sure.
Bottom line is, you may have this thing. There may be a posturing thing. There may be something that's causing compression on the nerves, and either an adjustment of her spine or some sort of procedure can take care of things. See, the point is, I believe that everything needs, it's yin and yang, okay? You're like the yin, I'm the yang. And the point is I think in a lot of these complex problems, you need a person who has more of a surgical sort of view, because you know what the double crush phenomenon is. There's the whole thing. I mean, I work with Susan McKinnon, who is a big expert on this stuff. I work with Lee Dellin, who introduced the concept 35 years ago. And you can have a lesion, and then all of a sudden you get something where your spine is off a little, when it magnifies things, and then you have a compressed nerve. And so the bottom line is, you don't know why this is. And I, unfortunately, I was just doing basic ENT. I was seeing all these people with terrible problems, but with my background, I said, look, we need to get this study. And they might have had a compressed nerve. They might have had something else. Like, for example, I went to my chiropractor. He's a very good guy. He's terrific. He was able, with an exam in 45 minutes, telling me the 9 problems I had with my spine. And he was able to put everything in position. Now, if I had gone to somebody else, they'd give me some damn pills and I'm running around. Whereas it was a simple thing of just, you need the inside out. And that's the whole thing I'm concerned. That's why this meeting I'm impressed with, because when I came last year, I like the fact it has groups of things. We actually look at stuff. And I think it's really important for surgical, physical people to work with the medical people, realizing also there's a psychiatric component. I got a master's in psych. I wanted to be a psychiatrist. So that's also important too.
And I assure you that I'm married to a psychiatrist. I never neglect the psychiatry component in this. I don't think we need to be either or. We can be and. So it's not that you are not going to have this patient evaluated for other things, for a block, for neurolysis if she gets recurrent blocks. It's not that you're not going to consider neuropathic adjuvants and or physical therapy. You have this patient in your office that is hurting.
So what was your diagnosis? I mean, what are you treating in your mind? What did you think you were treating? And then that's the whole point, is maybe that's not the primary problem.
Well, she was complaining of pain in her chest right where her mass was located that was radiating to her back. And so starting her off with something, because I have a 30-minute clinic visit with her, is really important to get her something to help her feel functional, especially for a young woman. I think we often practice or think we're practicing in ideal settings. The healthcare system is very challenging for our patients to navigate. It doesn't have to be either or, it can be and. We can do something for our patient while they are there with us and wait for the consultants that we need to get them into. For instance, this woman eventually did go to interventional radiology. At our hospital, interventional radiology does blocks does nerve blocks, they do neurolysis. So it doesn't have to be this sort of academic exercise of, am I going to do this or am I going to do this? It can be both. And I think when someone is there, part of the compassion and empathy in treating patients is seeing that they're suffering, especially a person with cancer, active cancer that is going on to treatment.
I agree with that. And the final thing, I don't want to,
Yeah.
but I've seen too many patients who ultimately went to interventional radiology, and that's still a medical track line. And the bottom line is, it could be, she might be sitting here and she keeps touching her chest and she's doing this and she's banging on the mask and it's then causing things. I think there needs to be, early on, there needs to be seeing all these different groups together.
We're going to go through this
You
case.
know,
and
I
we're gonna
think you're right. You know, it's a discipline.
We're gonna get to the
But, so
multimodal part, I
you
promise.
wouldn't give her any opioids. Is that what you're saying? I mean, it was a simple question. It's not, we're not treating her, but she's in pain. So right now, I guess the simple question, you did a very good job defending yourself. But what would you do?
Oh,
Are you going to use an opioid or not? If you want to say no, that's fine. But if you were going to use one, which one would you use?
And I promise you, I like these questions. I don't practice defensive medicine. I practice empathetic and compassionate medicine. And I think that for myself, having my own loved ones in the healthcare system, I want us all to remember we are human beings taking care of human beings. When someone is in your office hurting, they have a newly diagnosed cancer, 45 years old with 3 children, they have to be able to function. And you can send them to wherever you want to send them to. You should. And yet the healthcare system, I wish, and I don't know where y'all practice, I practice down the street. It doesn't work that quick where you can get in. And in fact, chiropractors are pretty damn expensive for people. I practice this in inner city New Orleans. There ain't nobody that can afford a chiropractor in inner city New Orleans. I don't know, do you all have work in places where they can afford chiropractors or where insurance is covering chiropractors? They,
Ooh, then I'll take it as a primary care doctor. So,
Can somebody choose an opioid,
tell-
please?
I do.
Somebody
Yeah.
choose one opioid.
Yes.
I'm
So-
glad we're having this discussion, right? Because we all have to recognize that we are all coming from different places and spaces and how to hear each other out so we are all humans, again, taking care of human beings. We cannot make our patients, we are not sitting here as the patriarchal doctors talking down. We should not be doing that. In fact, medicine has to be patient-centric. How do we help the people we have committed to serve? I get it, there's an opioid epidemic. I'm going to talk about that. How do we reasonably get people off of these medications as well? Because that's something that nobody's talking about.
So
Yes.
as a family practice doctor who also treats substance abuse disorder and performs acupuncture in his office and does ultrasound guided injections for pain, I feel uniquely positioned to answer this. So yes, I do multiple modality. We might do battlefield acupuncture in the office that day to help some.
Yes.
Now, if this were a test question, my answer is which opioid would I choose? If I had a multiple choice, any full mu agonist, oral, immediate release would be a good option here.
Absolutely.
Cool.
That's the only point I'm getting to is that at least, and you should do things. We have 6 physical therapists who needle within our hospital. So we do send our patients to physical therapy to evaluate for needling. We don't do acupuncture, and yet they do deep tissue needling. They can also do lymphedema treatment. So, you know, when you're starting opioids, the point of that is start low and slow. I'm not saying to start a long-acting pain. Start low and slow. You can do morphine, immediate release, any short-acting opioid at a starting dose, MSIR or oxycodone or any of the combined products starting it off. Because remember also, when cancer is in the body, you have circulating inflammatory mediators. Now, those don't bother everyone to the same level. Everyone has different levels of pain thresholds. Some people cannot tolerate pain well. Others can tolerate pain well. I know if, God forbid, anything happened to me where I had cancer, I probably would have a higher pain threshold, right? So everyone's a little bit different. And so I'm just asking us to think outside the box. Do the thing that can help the person be functional, and let's go through the exercises of acupuncture, physical therapy, multimodal, which I'm going to get to. She comes back, right? She comes back to your clinic. That, you know, opioid that you started at a low dose is not working. She's still having pain in that area. It's still radiating. Her labs are still normal. You want to adjust her opioids. What do you do? Well, you can actually consider if she is using opioids around the clock. You can, while you're considering physical therapy, multimodal pain control, and also acupuncture and all those modalities, those complementary modalities, considering a long-acting. Because right now her pain is spiking. She takes a dose of medicines, it comes down. Then it goes up, she takes a dose and it comes down. How to get her a little bit more level. When we start long-acting opioids, it's not on every patient. It's patients who are still hurting despite taking opioids around the clock. So we have this rule called the 2/3 versus 1/3 rule, or 3/4 versus 1/4, or half and half. Basically, you want to put more of the total oral morphine equivalent in a cancer patient into a long-acting. And so you can double her short-acting in the interim if you don't feel comfortable starting a long-acting, or if you start a long-acting, use this 2/3 rule, 2/3 versus 1/3, and make sure you keep the short-acting on in case she has those spikes of pain. I'm just going to show you the math on this, right? So if she is using oxycodone around the clock, 5 milligrams, Q4 PRN, 6 doses in a day, that's 30 milligrams of oxycodone. You multiply that by 1.5. That is the equianalgesia of oxycodone to morphine. Her oral morphine equivalent is 45. Then you can add a long-acting. Take 2/3 of the 45, which is 30, and you can start her on MS Contin 15 BID. The goal of starting a long-acting, and I explained this to patients and families, is to cut down on the amount of short-acting opioids they are using throughout the day. You had a question? Yes.
I do, and not to be a contrarian.
No, please.
The study that I'm semi-citing here is probably in the order of 8 to 9 years old, if I'm remembering where I got this from. But for chronic pain management, there was not a decrease in pain from long-acting compared to short-acting, but there's an increase in overdose deaths. Is there a different evidence in cancer pain?
There's different evidence in cancer pain, because cancer, the difference with cancer pain versus chronic pain is there's not an acute inflammatory component. Chronic pain is pain that lasts greater than 3 months, that doesn't have an acute nature to it. Cancer pain, as cancer is multiplying in the body, does release these inflammatory mediators, as we talked about, that can hit the nociceptors as well as that. So it's very different in chronic pain. Cancer pain is actually
shown that the long-acting provided better pain relief. I guess.
Yes. There is plenty of data in the cancer literature to show that long-acting pain medicines can help people to actually decrease the amount of short-acting and have better sustained control.
So related to that, this is something that I know about.
Sure.
What factors, you said her labs were normal. There has to be some mediators of inflammation that were positive. So what were those mediators, and why didn't people order them?
Because we don't always order those mediators. They're actually very expensive to run from a cost-effective perspective. When you're working in an urban inner city hospital, we often don't run labs when we know that a person has active.
So simple thing. How about a SED rate and a CRP? I mean, that's cheap. I mean, what is that? You know, and these are all basic stuff that needs to be, because I've done free radical research for the last 40 years.
Sure.
And there's all this stuff with inflammation. I didn't know how big inflammation was. I was just thinking of flaps, but inflammation's everything. So there has to be a way to monitor it.
When you actually look at CRP and ESR levels in cancer patients, they oftentimes are normal. And so that cannot guide what a person's subjective feeling of pain is. I hear the concern about pain as a 5th vital sign, and how do we actually measure up to that 5th vital sign? When you have an acute process like cancer, it is different. That is my big point here. If we treat cancer patients, active cancer patients like chronic pain patients, they come back and they hurt, they suffer. And I don't think any one of us, if we're diagnosed with cancer, would want to suffer through the treatments of it. It is different. And I want us to all think about cancer-related pain very differently than chronic pain, because it is different. So the next step is you can keep your short-acting the same, or you can double it, because the patient will need something for breakthrough pain. Now, if she's still having trouble pain, coming into the emergency room, admitted for an acute pain crisis, this is where coming up with a plan to treat. And the point of this is, can we use a PCA or a parenteral controlled analgesic device to treat her pain? So the answer is you can do IV opioids around the clock or offer them around the clock. Q2PRN. Your nurses on the inpatient side are not thrilled about that, but you can also consider a PCA for acute cancer pain. And so PCAs, for those, because I know I'm working, a lot of the audience is an outpatient audience. PCAs have different settings on them, a continuous rate, a patient-administered bolus, a lockout interval, as well as an RN bolus that can be added on top in case the person is having more pain, and an hourly max, which you don't need if you calculate the other factors. And so at your hospitals, you may actually have specialized palliative care or oncology cartridges that can actually go above the hard limits. PCAs can be very safe for patients because they have hard guardrails, so a person can't overdose. They can't hit it more than whatever minutes you designate it for. And I'm looking at the CRNA in our audience because CRNAs and anesthesiologists use PCAs quite often. And so if she is using this, and here's the math up here, if you started her on a long acting and then she was using her short acting around the clock, she's getting about 75 oral morphine equivalents. When we think about acute pain that requires ER and or admission, we generally will double what they are using at home and put it into a PCA so it's safe. And so the way we do that is we do the math, we do the back math. So 150 oral morphine equivalents, you give it over 24 hours. That gives you this much oral morphine. You can divide that by 3 if you want to give IV morphine. So that's 2 milligrams you could give her every hour. She can push the button and you can use that to see how much pain medicine she needs and where the changes need to be in your long acting. Does that make sense to everyone? Okay. If she's comfortable after you start a PCA, you can then recalculate her needs into a long acting and a short acting. These slides will be available to you so you can go through the math. And I would encourage you, practice the math because it works. The other things about acute pain management, because many of your cancer patients may get admitted for acute pain, is you should calculate their oral morphine equivalents and consider a PCA if they require admission, transitioning them to orals when possible, and not forgetting their adjuvant agents. Okay. Here's a methadone example for you all that I used with that equation. I had a patient who was on MS-Contin 100 3 times a day with oxycodone 30 Q8. He also was on gabapentin 800 3 times a day, Elavil 25. His QTC was normal. He went through physical therapy, didn't really help his osteosarcoma. Did try to do some needlings. A lot of physical therapists who do needling are uncomfortable with doing it around the cancer site. So they'll often try to find a location that they can sort of, take care of pain in a different way. This patient, when we did his methadone dosing, we did the same equation, oral morphine equivalent divided by 15 plus 15 divided by 2. He just died a month ago. And died comfortably. I had calculated an oral morphine equivalent of 435. And when I put this into the equation, I got 10 milligrams twice a day of methadone. And that's what I had him on. Yes.
In addition to changing the opioid, on a patient like this who's 800 TID of gabapentin, do you ever think about switching to pregabalin for better
We sometimes do. We sometimes do. And so pregabalin is presynaptic on the calcium chloride channel. Sometimes that can have effect. He had been on pregabalin before and did not find that it worked for him. The other problem with pregabalin, we'll talk about the neuropathic adjuvants. Many insurances will not cover Lyrica. And it is a real pain in the butt to get it approved. But he had tried pregabalin in the past, and I think was on 225 twice a day, which is pretty max dose. It's actually beyond the max dosing, and it didn't work for him. So unique populations to consider when managing pain, dying patients. Not every dying patient has to be on a continuous infusion of morphine. In fact, when people are dying, they need bolus doses. So using Q15 minutes as needed bolus doses for immediate release. When you need to start a continuous infusion, that means the patient is using multiple bolus doses. Remember, as needed doses work a lot quicker in dying populations. And if they are using multiple doses of that, then start a continuous infusion. So the days of starting an 8 milligram an hour drip or a 2 milligram an hour drip and titrating it every hour, don't do that. give them boluses so that they get immediate symptom relief. The pathophysiology of sickle cell, and this is the next population I want to talk about, is sickle cell is not always acute pain. It's oftentimes acute on chronic pain. Patients develop hypoxia, they have ischemia, which activates their nociceptors, and there's inflammatory mediated tissue damage. And so this vaso-occlusion occurs, which causes an acute on chronic pain. Oftentimes, patients with sickle cell are having sickle cell episodes all the time, to some level of degree. And so they do develop more chronic pain and sometimes acute on chronic pain. So factors that can precipitate acute pain include infections, low oxygen tension, dehydration, acidosis, if they have extreme physical exercise or psychological or physical stress, alcohol, pregnancy, cold weather. Here in New Orleans, we have a very large population of sickle cell patients. I often will ask them, do you get more crises in the winter when it cools down or in the summer when it gets hot as hell? Because it gets real hot out here. There's a lot of humidity as well. And those times, I give them a little bit more opioid to manage their pain. And then I wean them off during their non-crisis times, because I know that these factors will be a lot less in their non-crisis times. Sickle cell pain, the pathophys of it is sickle cells, which cause inflammatory mediators and then damage from vaso-occlusion. So this is a combination of pain. It's not just vascular, it's not just neuropathic, it's not just bony or musculoskeletal, it is also chronic in nature. And so acute pain for patients with sickle cell, the average hospitalization is 9 to 11 days in adults, 4 to 5 days in kids. PCA use in patients with sickle cell has actually been found to lower the number of days in the hospital. And generally it is, when people are using PCAs and can push the button rather than if they're on continuous opioids. And adjuvants are really important in sickle cell pain. Things like your NSAIDs that can really help to decrease the inflammation. Now, NSAIDs in cancer populations are frowned upon because we want platelets to work well. And so, we try not to use NSAIDs in cancer-related pain. However, in sickle cell pain, they're pretty standard of care. Chronic pain is usually from complications or recurrent sickle cell crises, so avascular necrosis or leg ulcers. And so we do a multimodal management with sparing of home opioids in this particular pain population. The American Society for Hematology actually came out with guidelines in 2020 around sickle cell pain and especially acute pain crises for sickle cell. That analgesia should occur within 1 hour of ED arrival. We should be using fluids to decrease and minimize inflammation, and we should minimize that in adults because of the risk of fluid overload. We should use individualized care plans, and when we're thinking through pharmacologic management, combining opioids with NSAIDs and then neuropathic adjuvants, and if possible, ketamine. Now, every state has different rules on ketamine. Here in the state of Louisiana, we cannot use ketamine on our hospital floors. It requires an ICU bed because nurses on our floors are not allowed to titrate ketamine doses. And so we're not able to use ketamine in the state of Louisiana for acute on chronic pain here, or even for chronic pain, really. The non-pharmacologic management of sickle cell pain, thinking through blocks and neurolysis, thinking through biofeedback, acupuncture, massage, cognitive behavioral therapy. Now, how many of you have been able to get insurance to cover acupuncture or massage therapy? It doesn't happen. And when we're talking about sickle cell pain, many of our sickle cell patients are on Medicaid, right? On state Medicaid plans, and they certainly don't cover acupuncture or massage. Heck, we have trouble finding psychiatrists and therapists that will take Medicaid to do CBT. In our palliative care team, we have a licensed clinical social worker who is well-versed in CBT and DBT, and so she does a lot of therapy with our patients. So chronic sickle cell pain generally is from the complications of it. The bone infarcts, the avascular necrosis of joints, the contractures from strokes, the hepatic and splenic sequestration, which causes visceral nociceptive pain. And then also don't forget to consider drug-induced constipation. That can cause pain. So we need to treat constipation so that's not contributing to pain. And the neuropathic involvement from tissue damage that occurs from chronic sickle cell crises. So some tips for sickle cell management: treat the underlying disease with hydration, hydroxyurea, exchange transfusions. Don't flood your patients with fluids, and then consider a multimodal approach similar to what you would do for your chronic pain population for sickle cell. I want to talk about empathy in the practice of medicine, right? And so empathy is walking as if you're in a person's shoes, knowing full well none of us are walking in our patient's shoes. And so it allows us to gain insight into what our patients may be going through, really helping to build rapport. However, this can be very challenging when we're working with chronic pain patients. It's a little bit easier for me when I'm working with active cancer patients because I have an active reason for why they're hurting. So really, we should try to be as empathetic as possible. And so some communication techniques to build empathy, utilizing the prescription monitoring program, like Dr. Prasad talked about, when you are prescribing opioids, making sure you're communicating with your patients about what's working, what's not working, and then setting boundaries with them. You are not there to prescribe 360 tablets of opioids, right? In fact, in our clinic, we're a palliative care clinic. 80% of our population is active cancer. We only prescribe 90 opioids per month. So every 8 hours, 3 tablets per day if a patient needs it. And then we talk about the rules of our clinic and why we do that. And then if people need something else, we're considering adjuvant agents, long-acting agents, all of that. Opioid contracts don't always work. There's data behind opioid contracts. We have to use them for safety and for guidelines for patients, and then paternalistic communication. I've been guilty of this myself, where I've been paternalistic in my approach towards certain patients, and I can tell you they don't like it, that's for sure. When I'm more empathetic and explaining things and take the time to do that, it's a lot better for the patient and for my own well-being. So I don't have 2 minutes for a stretch break. If anybody needs to stretch, please get up and stretch. But I'm going to talk about chronic and multimodal pain management. I know that Dr. Prasad spoke about some of these techniques. I'm going to elaborate on them. So key management points in chronic pain. Opioids are not the mainstay of treatment, right? They can be used sparingly. And when we're talking about chronic pain, we are talking about pain that has been present for greater than 3 months without a defined source like cancer, okay? And then when we think about this, we really should do this from a multimodal standpoint. So use of adjuvant agents, gabapentinoids, TCAs, SNRIs, use of Tylenol, NSAIDs, muscle relaxants, which often don't get used, and then complementary methods. I don't call this alternative medicine. I call these techniques complementary to whatever else I am doing. So the use of acupuncture, needling. How many of you have used TENS units? Yeah, TENS units are great. I use it for my back as well because I have some injuries from being a tennis player for a long time. And so I use a TENS unit. The problem is TENS units are not covered by insurance. Their data is best in the post-knee arthroplasty population. However, if you call the insurance agency, oftentimes you can get them to cover the TENS unit for the patient. TENS units are electrodes that are placed on certain muscular regions that deliver an electric shock, resetting the neuropathic response of the pain. And so it can help in musculoskeletal, bony, and neuropathic pain. And then use of physical therapy. Many of your physical therapists are trained in needling approaches. And don't forget mental health. The challenge is finding psychiatrists, finding therapists to attend to our patients is really difficult. And I'll tell you, CBT is cognitive behavioral therapy, reframing things. Many of us are actually moving more towards DBT, which is dialectical behavioral therapy, where we meet people where they're at. We don't ask them to reframe the pain they're going through. We ask them to meet their pain where it's at and move forward with it. I have a patient right now with IBD, and I didn't talk about inflammatory bowel disease. That's another unique population when caring for their pain needs. I have a 25-year-old right now who's using about 400 oral morphine equivalents, and he continues to want IV opioids. We have a bigger discussion of his mental health to talk about and his developmental stunting. He's probably about developmentally at the age of a 12-year-old. So talking to him about dialectical behavioral therapy, we hear you that you are in pain. And we need to find ways outside of the opioids to help in treating your pain. The challenge is most physicians don't have the time to do therapy with their patients, right? Most psychiatrists are not even doing therapy with their patients, right? And many of our therapists are out-of-pocket expenses that our patients cannot afford. So keep that in mind, when considering this, not to say that you shouldn't do it. There are some real systems-based challenges in being able to provide all this. So I'm going to move forward with Miss B, and I promise you, I didn't just give her opioids. I did consider an adjuvant agent, and her kidney function was normal. So I did consider some adjuvant agents. So always consider these early, and they can be used with opioids and cancer-associated pain because cancer and its inflammation can impact the nerves, the muscles, and the bones. And when people have bony metastases, that can really impact their care. Also, your neuropathic adjuvants, your other agents like muscle relaxants can help you when you're weaning your opioids. And yes, we do wean patients off of their opioids. So going back to neuropathic, bony, musculoskeletal, and chronic and psychosomatic pain, adjuvant agents and why they choose them. I like to think of this as go low and slow, which Dr. Prasad said as well. And then also hit 2 to 3 birds with one stone. So when I'm considering adjuvant agents, I'm actually referring to, if anyone wants to look up the Cochrane review, that is where most of this data comes from. There's a Cochrane review, and Cochrane reviews are meta-analyses that pull together multiple studies and come up with best practice guidelines. There is a Cochrane review on neuropathic pain, which actually found that the best agent for neuropathic pain, the lowest number needed to treat is how many patients you have to treat to achieve a therapeutic response, was for TCAs. So if I have a patient who is not 65 and older in the aging range and can tolerate a TCA like Elavil, amitriptyline, or nortriptyline, is having mood issues, I start them on Elavil at night, or having sleep issues. The other thing is you can use gabapentinoids, right, for sleep as well. Gabapentinoids also back in the days were the original mood stabilizers in bipolar disease. So for my patients who have anxiety or they have sleep problems, gabapentinoids are good options for that. SNRIs, including venlafaxine, can be very activating. So for my cancer fatigue patient population, I use venlafaxine as an adjuvant agent to get them perked up a little bit more. Duloxetine tends to be a little bit more sedating. The other patient population that works well with venlafaxine, hot flashes. It works also for hot flashes. So any women in the audience who are going through menopause or premenopausal, venlafaxine can be your best friend. So those are the big things on that. So other therapies, patches and creams, using lidocaine patches. Now, I also have a poor man's lidocaine patch because insurance often will push back on approving lidocaine patches, the 5%. So what you can do is prescribe a 4% cream, which insurance will cover, and give your patients Tegaderm from your clinic so they can make their own lidocaine patch for whatever region they want to apply it to, or just give them some gauze and some tape and they'll tape it on, right? Even cheaper. Capsaicin, I say not in neuropathy, and yet for some patients it does work. Capsaicin creams can work for neuropathic pain. Ketamine. Ketamine is great. I wish in Louisiana we had more access to it. If you practice in a state that has access to ketamine, it's not approved yet for, anything other than depression. In the chronic pain world, it's used for resetting of the receptors so that you can use lower pure mu agonists, but we're not able to use it here. And patients do need to come in and actually get a ketamine infusion. For us, we don't have outpatient ketamine clinics here. They're not approved by the state board, so patients have to come into the hospital. And you can only imagine hospital administration does not want us taking a hospital bed to reset a chronic pain patient's receptors, unfortunately. So some fiscal challenges with that. And then PT, acupuncture, and needling as another multimodal approach to pain management. Now, when you wean, and I would encourage everyone to wean, when my patients go into stable disease status from their cancer, or in cancer remission, I wean, and I give the choice to them. Would you like to wean the quantity of your opioids by 10 per month, or do you want to reduce the dose to start off with? knowing that we're going to wean you all together. Most patients with cancer, we can wean them off of opioids completely. There is the small population that has really bad neuropathic pain, like our multiple myeloma patients that need like 15 tablets a month. They use them very sort of sparingly. And that's okay. We work with our PCPs to make sure they feel comfortable. But the eventual goal is we are weaning opioids to a minimum because opioids are probably not good. Well, they're not good. I'm not going to say they're probably not good. They are not good long-term. They do cause cognitive damage and cognitive remodeling. And I explain that to patients. This is what I'm trying to avoid. And so I want to wean your opioids. Journavax. This is a medicine that Dr. Prasad brought up, the suzetrigine. This is a newer modality in the world of acute pain management. It has been studied. It targets the VIP36 and CB1 receptors. So essentially, it's working on sodium channels, similar to how TCAs work. There is a big study out there right now on suzetrigine that looked at patients post-abdominoplasty and post-bunion removal. Yes, you heard me right. Abdominoplasty and bunion removal. And the makers of this found that it did help to decrease the amount of opioids. I will encourage you all to read the study. I was not impressed. That is my opinion on it. I think that we still need a lot more work done on Journavax to see if it works in the acute pain population and which populations it'll work on. And certainly there is no data yet to suggest it for chronic pain use. The other thing is it is very expensive, $15 per tablet and not insurance approved. And the study was very flawed in terms of the patient population that it looked at, a very homogeneous patient population that doesn't necessarily reflect the population that I practice. And then virtual reality. So it's interesting to watch aging patients wearing those virtual reality glasses, and yet virtual reality is another modality being studied for more chronic pain, for neural reprocessing and distraction. So there's my little old lady wearing that. I would love to be that little old lady one day wearing VR glasses. So look for the red flags when your patients have multiple allergies to different opioids. Look for the red flags. Many of your patients will prefer Dilaudid, IV Dilaudid or PO Dilaudid or oxycodone, because those two opioids work on the kappa receptor in the brain, which is your euphoria center. So if you remember PCP, LSD, Rohypnol, or Roofies, they work on the kappa receptors. So be wary of those patients who say the only thing, doc, that works is IV or oral Dilaudid, right? Multiple doctors or doctor shopping. It's why it's really important to check the PDMP when you're prescribing opioids. Those who are unwilling to try multimodal therapies and those patients who have multiple ER visits or pain contract violations. This is what the prescription database program looks like when you look at it on your state. And you can check another states as well. I believe there's 30 some odd states on the PDMP. How often should it be checked? Each and every time a new script is written. So even for refills, we check the PDMP each and every time. Ethical issues in chronic pain management, the access to chronic pain doctors is really poor. And in fact, in Louisiana Medicaid does not pay for chronic pain management. So our patients can't even get into chronic pain doctors. It's why you all working in the outpatient setting often are the first line for patients with chronic pain. We don't have a medical model. There's a scheduling bias. There's often bias because of the opioid epidemic about treating patients with chronic pain. And there's really a community lack of specialists. There's misconceptions about pain management, drug diversion concerns, addiction concerns, non-compliance, and then failures to recognize pseudo-addiction. And so all of us stand to sort of improve our knowledge in this. And then also the fear of law enforcement. Although, the government opened back up. So for a month, we were safe with everything while it was shut down. So a summary of this. Knowledge of opioids leads to effective use and prescribing pattern. And certainly in your acute cancer pain population, don't be scared of opioids with the other modalities, with the multimodal approach, the neuropathic agents, the complementary therapies. Always calculate your oral morphine equivalents. And chronic and acute pain should be managed with a multimodal and empathic approach. Those are my references. And here are some important resources if you want to do more reading. Vitaltalk.org is a patient-doctor communication skills website. It has videos on how to empathically communicate with patients. The HAPC virtualdidactics.com, I'm actually one of the faculty on that. We have monthly free lectures with CME included on different topics within palliative care. Palliative care fast facts. If you need to know how to start a fentanyl infusion, there is a palliative care fast fact on how to do that that has evidence-based. And they're one-page evidence-based articles in palliative care topics like starting fentanyl patch, starting methadone, all of these things. And then the Vital Tips from Vital Talk actually is a smartphone app. Those are my email addresses, and that concludes my talk. Thank you so much.
Thank you, Dr. Malhotra. Again, tomorrow, a few housekeeping things. Well, just remember, we're going to restart here at 8 o'clock, breakfast from 7 to 8, I think right across at St. Charles. And I think we have just a few minutes. I know you'll stay a little bit longer to answer some questions, but maybe we can just address 2 questions real quick.
I have 4 minutes.
That was quick.
Everyone's scared now. Don't be scared. I promise I don't bite.
As an internist, I'll ask you a question.
Yes, sir.
Oh, okay, go.
I want to thank you for a very impressive and very informative presentation. I know that as a psychiatrist, it's good to know that your husband's having an influence on your appreciation for mental health issues.
Yeah.
Is there anything in particular that would help non-palliative care doctors, I guess, just set the frame for helping patients understand that that's a very important aspect of their treatment?
Yeah, that's a great question. I would say that it is okay to be vulnerable to patients. If we talk about our own, and I tell patients often that I have a pretty extensive living will. And, you know, our attorney laughs because I have probably one of the most detailed living wills he has ever written in his career. And I normalize that. And so for you to speak to your patients about the normalization of a living will, how many of you all have a living will and a medical power of attorney? Thank gosh, majority. Those who don't, please. And I have to tell this to my residents who are young and they're like, well, why do I need one? And I'm like, we work at a level 1 trauma center. Trauma doesn't differentiate whether you're old or young. It can happen to anyone. And so I think normalizing some of these things, using statements, being empathic, like I'm worried, or I'm wishing for this, or I'm hoping, being able to normalize that, either when talking about palliative care, end of life challenges, or about responsible pain management. I wish I could prescribe you 360 tablets of opioids. I can't. I have to be careful with my license. And I use this phrase a lot with my patients. I have worked really hard to get this medical license, and I can't lose it over one patient because then my thousands of patients will suffer. So I think if we show some vulnerability, our patients can and will respond better. And if we normalize things, and I promise you, I am not this hokey pokey, toxically positive person. I come with a very healthy dose of realism. I grew up in a really tough neighborhood in Southern California. And so I am not this like toxically positive, everything's gone well in my life. I grew up from rough roots, and I normalize that for my patients who live in inner city New Orleans. I don't know everything you're going through, and yet I have some semblance. I have some knowledge of what that life is like, and I want you to do better. And I know you can do better because I did better. So normalizing it, being vulnerable to patients, we have to be humans taking care of humans. I hope that.
What passion, what an advocate. You can always get them to join SMA because this is videotaped and they could watch it. I mean, I think it was an outstanding presentation. One more question? Yes? I'll ask mine. Movantik, I don't know. I guess it's something that I use. You know, it's expensive, but why don't they make combination medicine? Because it works for opioid-induced constipation.
Oh, that's a great question. So opioid-induced constipation, we want to use the laxatives first and foremost. And then when they're not working, we can use the Movantiks and the Linzess. My hope is that we can get insurance to actually start covering these modalities because it works. Also, if you work in a place where naltrexone is covered, where it can be compounded, that can also work for opioid-induced constipation. But yes, think about the Linzess, the Relastors. Relastor is much cheaper, methyl naltrexone now, for opioid-induced constipation. So when your patients are not working with a combo of multiple laxatives, then moving upwards towards those more hard-hitting sort of mu receptor antagonists is really important. And combination therapy. Don't just do Senecot without the Miralax. If I have a patient who's not pooping, I'll do Sena and I'll add Miralax, and I tell them take it 4 times a day. Most people don't want to do that. And yet, trust me, Miralax is so easy. I'm a pediatrician as well. We use it in kids all the time. It really will clean people out.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.